We've all experienced it. We've gone to our PCP or general practitioner for our yearly physical. We've had our blood drawn and we've received our cholesterol results, and the total cholesterol and LDL are lab high, and your doctor is now recommending that you take a statin drug. Should you take the statin drug? And how definitive is that lipid panel that was done in your doctor's office in terms of predicting your cardiovascular risk for heart disease and stroke? I'm Dr. John Bartemus, and I'm putting the pieces together to help you live a life at optimal. The lipid panel is a very basic panel looking at total cholesterol, LDL, HDL, and triglycerides. It is a screening panel to help us understand how you metabolize lipids and potential cardiovascular risk. But the more research that is done, the more it says that the lipid panel as is, that is standard in a conventional medical office, is not the best predictor for cardiovascular disease risk and not as good as other widely available markers. And so if that's true, then why should the conventional medical model reflexively just pollinate the world with statins if we know that that's not even a good indicator of your cardiovascular disease risk? What the lipid panel really says, if it's off, is, hey, we need to look deeper. We need to look deeper in many areas. We need to look deeper at your lipids, at your lipid metabolism, so more thorough and in-depth diagnostic testing, which we'll list for you today. We also need to look deeper at causes of lipids being lab high. So what would drive up cholesterol and LDL? Well, any sort of inflammation. So if you've had recent trauma, recent surgery, infection, autoimmunity, cancer, all kinds of things that can happen physiologically to cause you to be inflamed and therefore raise your lipid panel. So we need to investigate those things to be able to determine if the lipid panel is really related to increased cardiovascular disease risk or if it's increased because you're infected, et cetera, et cetera. So for the purposes of this video, let's say you saw your GP, your total cholesterol was lab high, your LDL was lab high, and your HDL was in the normal range but lowish. That's probably a pretty typical finding for the average American. Well, instead of just taking the statin, which is a Band-Aid or a piece of duct tape over the check engine light in your car, instead of doing that and just covering up the symptom and letting whatever the cause is continue to burn underneath, we want to do more in-depth lipid testing to understand, does this lab high total cholesterol and LDL equate to an actual increased risk of heart disease and stroke in you? And so the tests we want to do that, or the tests we want to run to be able to answer that question will be listed right now. So we want to see that lipid panel, and then the next layer deeper we want to investigate includes apolipoprotein A1. Apolipoprotein A1 is an indicator, or is the most common or the highest amount, or makes up the majority, of lipoproteins in HDL molecules. So this is a great indicator and a better indicator of the amount of HDL or good cholesterol in your blood than HDL itself is. So the higher these numbers, the higher the amount of HDL in your blood, which would be determined good by conventional medicine, because HDL takes cholesterol from the vessels or from the periphery and to the liver to be metabolized. Hence, that's considered good when compared to LDL or bad, which takes cholesterol from the liver and deposits in the periphery. But why is that bad? If you're inflamed or have tissue damage, that's actually the intelligent adaptation that you want. Otherwise, the tissue damage continues, and if it's in a vessel, maybe you're bleeding out. So we don't necessarily want that, okay? Apolipoprotein A1 tells us a better indicator of how much of your lipids are HDL. Apolipoprotein B. ApoB tells us about that makes up the most or the highest fraction of lipoprotein in LDL particles. So this gives us an idea of the amount of LDL and the atherogenic particles in your blood, so the pro-plaque forming cholesterol molecules. So ApoB, the ApoB to ApoB ratio is a better predictor of cardiovascular disease risk than anything in the normal lipid panel that we get at our physical. We also want to see lipoprotein little a. Lipoprotein little a is an indicator of, again, cardiovascular disease risk, an independent risk factor for it, and this one has a highly genetic contribution to it. So if you were to run your lipoprotein little a and it's lab high, you're not expected to be able to change that number a whole bunch because of the genetic contribution to that being high. But what that would tell us is that genetically you have an increased susceptibility or risk for cardiovascular disease because of these levels. And then we also want to understand what your ApoE genetic profile is. You may have heard of ApoE in the news because ApoE is related to Alzheimer's disease risk. So what ApoE is it's looking at the genetic susceptibility for cholesterol metabolism and how that's associated with Alzheimer's. So if you have an ApoE 4-4, then that is the highest risk presentation for Alzheimer's disease. There's a 40 to 60% increased risk that you will have Alzheimer's disease. It doesn't damn you to Alzheimer's disease because 30 to 50% of Alzheimer's patients don't have this presentation of ApoE. So it's a risk factor. You're not damned to it, but whatever your result is here is what you're stuck with because that's genetic. So we can't change your genes, but just because you have the gene doesn't mean it's going to manifest in the associated disease, in this case, Alzheimer's. So this is the more in-depth lipid testing that we would want to see if your lipid panel is off and if your doctor is recommending a statin. All of these are, these two can be addressed by lifestyle and supplementation and those sorts of things. They can be changed that way in absence of a statin, and therefore you can reduce your cardiovascular disease risk by changing your lifestyle without taking a statin. These two have a more genetic component, so ApoE is not going to change. Lipoprotein little a probably not going to change much, but it's still interesting to track the lipoprotein little a in each individual because some individuals may change more than others. Other markers that are not lipid markers but that are known independent risk factors for cardiovascular disease and that tell us more than the lipid panel does about your risk for cardiovascular disease include high sensitivity C-reactive protein and homocysteine. So those are great markers to throw into the panel to get an idea. And one other one would be fibrinogen, which tells us about your risk for clotting. So if you have had a high lipid panel at your GP's office and they've recommended a statin and you haven't first tried the recommended 6 months of intensive dietary and physical exercise change, then first try that because that's supposed to be the gold standard recommendation before the statin. And then while you're doing that, get more in-depth lipid panel inflammatory marker testing so that we can understand further what your cardiovascular disease risk is, and again, would a statin be necessary in your case or not. So I hope this was educational and opened some eyes and sends you down the further testing rabbit hole so that you can know more about yourself and understand your cardiovascular disease risk both now and in the future.